Thank you for those kind words, and for me it's a real honor and pleasure to be standing here, especially since I've got my lovely friends, family, colleagues here, many of whom in this room actually who've contributed to me sort of standing here today. So what I hope to do in the next 35 to 40 minutes is just take you through my most amazing journey that landed me in Brighton. And while I'll be focusing mostly on my research in Brighton, I will also touch upon the work I did before I got here. It's an old photo, but that's me in the middle, my sister, my brother, and my parents. And I must admit, my academic career actually had a pretty disastrous start, because when I became a professor, I obviously called up my parents, who are not here today, but they are in spirit, I know, because they couldn't actually make the flight from Delhi. But when I told my mom, she told me something she'd never actually told me before. So when I was born, apparently they had to use the forceps to get me out. And my mother was so scared that my brain had somehow been damaged, you know, with the forceps. And her fears were confirmed when I started school, and I actually failed really badly in my first 2 or 3 years in school, such that the teacher had to meet my parents and tell them that I think this girl really has no future. I think that her attention span is so short that I don't really hope much. I mean, I don't really have much hope for her. So I think after that, whatever I've achieved has been a real bonus. So after that disastrous start, I did actually make it to medical school, and I went to 3 different medical schools: the Armed Forces Medical College, Lady Hardinge Medical College, and then I went to Maulana Azad Medical College, which is in Delhi. And you probably won't recognize me, but when we were in medical school, we had a freshers week, and all the women had to wear saris, and I couldn't even recognize myself here, so I doubt you guys will. But that's me more than 30 years ago, and I didn't even know actually that I had this photograph. So after I finished my training in Delhi, I did my post-graduation, and then I landed in the UK in 1992, and I trained up north. So I did my training in Hull, York, Leeds, and while I was in Hull, I actually wrote my very first paper exactly 20 years ago. And this was only a little case report, but it was based on ascites, which is the fluid that develops in the abdomen of people once they have severe liver disease. And almost every reference that I looked at on ascites had just one name: Bruce Runyon. At that stage, I had no idea who he was, but remember that name because it's actually going to come up again. And it's amazing that I write my very first paper on ascites, and subsequently my research is actually also focused on ascites. And then by some real twist of fate, I was really lucky to be appointed as a hepatologist at this amazing institution, which is the University of Southern California. And while I was there, guess whom I actually worked with? So the guy in the beard is Bruce Runyon. So you can imagine the very first paper I write on ascites, and I actually end up working with the father of ascites. So he has written all the guidelines. He has developed, you know, almost everything that we know of ascites in liver disease. And the person on the left here is the late Telfer Reynolds and Alan Rediker. So these are doyens of hepatology. They are contemporaries of Dame Sheila Sherlock, who was a very eminent hepatologist, and between them, they were the first ones to actually establish the concept of liver units. And while I was there, Telfer Reynolds actually retired, and when he retired, he was given a personal gift from the university for $20,000. And what does he do? He gives it to me as my very first research grant. And I can't really imagine anyone now doing something like that. So that was my, sorry. So that was my first grant. It's always actually held a really special place in my heart. And people often ask me as to why I became a hepatologist. And in fact, when I met Malcolm for the first time, that's exactly what you asked me, Malcolm. What actually why did you become a hepatologist? I don't know the answer to that. I've always had a passion for hepatology, but I guess the fact that I could work with such fantastic people, I think further fueled my passion and desire for hepatology. And that money which I got, the $20,000 which I got, I then subsequently used it for some research which I will talk about. And the other person that I worked with was Karen Lindsay. So she was amongst the first ones to actually use interferon, the older treatment that we used to use for hepatitis C. And of course, not to mention Neil Kaplowitz, who is the guru of drug-induced liver injury. So after working with such fantastic people, there was no doubt that I would eventually become a hepatologist myself. And the first study which I did in when I was in California was this study which has been cited over 100 times. And this was actually looking at outcomes in people with a condition called as autoimmune hepatitis, which is an immune condition that affects the liver. And in those days, and this is in early 2000, all the guidelines said that remission, or when the disease is in good control, is defined by liver tests which are less than 2 times the upper limit of normal. But what we showed in this study was that what was most important in this disease was to have normal liver tests while on treatment. And I'm pleased to say that after this study, there were some other studies, and then this study actually informed all the subsequent guidelines on autoimmune hepatitis, and all the recent guidelines now very explicitly state that remission in autoimmune hepatitis is defined by normal liver tests. And the second, I think, important study that we did, which has been cited in excess of 50 times, was the study looking at drugs to treat HIV. So these drugs are known as highly active antiretrovirals, or HAART, and we know how beneficial they are in people with HIV. They actually save lives, but there was a lot of concern when these drugs first came out that they could actually damage the liver. So we looked at our own data in people who had HIV and hepatitis C, and we looked at the impact of these drugs in these individuals, and what we actually found was that HAART not only benefits people with HIV, but if you have HIV and hepatitis C, it actually benefits the liver as well. And there were a number of sort of subsequent studies after this, and again, this has been actually quoted by most guidelines in people, which have been written in people with HIV and hepatitis C. After University of Southern California, by an even greater twist of fate, I found myself at Johns Hopkins University Hospital. And this hospital is consistently rated even now as one of the top hospitals in the world. This and Harvard often vie for the top spot. And for me, that year that I spent here was absolutely inspirational. I think the who's who of medicine has worked there. So the wards in which I was working was named after these people. So there was a William Harvey ward, there was a William Osler ward, Blalock Tosek ward. So all the great people in medicine had worked here, and it was a truly great inspirational experience to work here. I emailed Johns Hopkins to send me the photograph of the faculty when I was there. They sent me one with just 1/5 of the faculty. So the top, you can see the top, the first row is the faculty, and they had 50 faculty in gastroenterology and hepatology. So there were 25 academics, and there were 25 sort of clinicians. And the person who actually recruited me is Paul Tholoworth. And after that, I land in Brighton, and when I land here, my line manager, Kevin Davis, when I meet him, so I ask him, so Kevin, what about the rest of the faculty? And he said, Dr. Verma, you're it. This is and I'm still it, but I'm hoping that we will soon be having another academic soon. Okay, and sort of undoubtedly, you know, as one of my mentors always told me, your research is only as good as the data you have. And because they had the most fantastic data at Johns Hopkins, some of my best work was here. And this is one of the largest studies which involved over 20,000 people looking at the impact of obesity on outcomes after liver transplantation. And this work has been cited more than 200 times. It's informed all the guidelines. And what we actually showed was that once your BMI started to go above 40, and you can see here, your mortality or your death started to increase. And the second important study that we did, which has been cited in excess of 300 times, again, this study involved more than 20,000 people looking at the impact of renal dysfunction or kidney problems in outcomes in people after liver transplantation. And this is quite important because if you have underlying kidney disease before transplantation, it does affect your survival, but there were no clear sort of guidelines or evidence as to what degree of renal dysfunction you have to have. And what we showed in this study was that if your creatinine clearance started to go below 30, it was associated with significantly poor survival both of the transplanted liver and of the individual. And this is important because many of the prognostic markers that we use, or the prognostic scores that we use to assess survival after transplantation, actually have creatinine built in. And the third work which I did at Johns Hopkins, which has again been cited in excess of 100 times, was looking, again, one of the first few studies to actually look at the impact of ethnicity on outcomes in people with an immune condition that I've already mentioned, which is known as autoimmune hepatitis. And we were amongst the first ones to show that those individuals who were Africans, especially if they were African men, had a significantly poor outcome. And then I landed in Brighton, and it's amazing how sometimes you can take months and years to make a decision, but my decision to come to Brighton was made really within minutes. And I must say it has turned out to be one of the best decisions that I've ever made. Now clearly, if you're working in a transplant center, you can do research on autoimmune hepatitis, you can do research on transplantation, but if you're working in a secondary center, clearly I had to quickly switch gears and focus on things which were more relevant to Brighton, especially alcohol and hepatitis C. Well, that's obvious, isn't it? And here is John Potts, who's here. So he was and here he is with his lovely wife, and he was our first research fellow. And I think when John started, it was quite like the same time when I had started. So it was more like the deaf leading the blind, John, if you remember. They were tough days, but John really set very, very high standards. And one of the first works that he did was looking at outcome in people who have a severe inflammation from alcohol, and this is a condition called as severe alcoholic hepatitis. And what he showed very, very elegantly was that in these individuals, once they come into hospital, if they stop drinking, their 5-year survival is excellent, but if they continue to drink, it's absolutely dismal. So a dramatic difference in survival if you continue to drink versus if you stop. And this paper was actually published in APT, and it's not often that an editor of a prestigious journal actually emails you to say that I think your paper is really clear and powerful, and can you get your hospital to do a press release. And we actually did have a press release on this, and even though this work was only published about 5 years ago, it's already been cited in excess of 50 times. And the other important work that John did was again quite novel. So in patients with alcoholic hepatitis, there is evidence of certain cells that move into the liver, and these cells are known as neutrophils. And these cells are important because if you have evidence of these cells in the liver in this condition, it has a prognostic value, as well as it indicates those individuals who are likely to respond to medication. And previously, no one actually has been able to image these neutrophils in the liver. So what John did in a very, very elegant manner was that he took white cells from people with this condition, alcoholic hepatitis, and he labeled them with this radioactive indium, and then injected it into these patients, and then imaged them 30 minutes before and 24 hours after the injection. And this is what someone's liver looks like at 24 hours, whose normal liver, and you can see how dark this liver is, and this is because this individual's liver is full of these neutrophils which have aggregated in the liver. And we then correlated this with liver biopsies, where we correlated these findings on imaging with evidence of neutrophils in the liver biopsy. And there's immense potential for this, because currently we can only make a diagnosis of alcoholic hepatitis on biopsy, but this may, once we refine the technique, may give us a non-invasive way to make a diagnosis of alcoholic hepatitis. Okay, so now I'm going to be focusing on hepatitis C, and I'm going to be focusing on improving symptom burden in cirrhosis. So here is this little virus, hepatitis C, only discovered about 30 years ago. And you can see Alan Redeker, one of my mentors in the States, who's actually a co-author on this paper. So, this is quite a nasty little virus if it is not treated. And the problem was that most of the individuals who have this virus in this country are very vulnerable adults. So, they are people who inject drugs, they are the homeless. So, these are individuals who don't really actually engage with health services. And the other problem with this virus was that the current treatments that we had to treat this virus were really toxic drugs. So, you had to take prolonged 12 months course of treatment with only about a 50% cure rate. But things have dramatically improved now, and we have these fantastic new oral drugs which are known as direct acting antivirals, which is just a pill a day with a near 100% cure rates. And undoubtedly, the discovery of these direct acting antivirals has been the most fantastic, amazing discovery in hepatology over the last 50 years or so. So amazing that now the WHO, the World Health Organization, wants to eliminate this virus by 2030. And if we eliminate this virus, it's going to be the first infectious agent to be eliminated without a vaccine, which in itself is a fantastic achievement. The last infectious agent to be eliminated was smallpox, but that required a vaccine. So, this is absolutely amazing stuff. But we are a long, long way away, because as you can see, deaths from hepatitis C have actually overtaken deaths from TB, malaria and HIV. And honestly, I never thought I would live to see this day where we would be seeing this. And the reason why this is happening despite the fantastic drugs is that the vast majority of people with hepatitis C are actually undiagnosed in the community because they do not engage with health services. And in the past, we have tried to engage these individuals. So, in 2012, we took one of our hepatitis nurses and placed her in the large drug and alcohol service to screen people and then refer them on to the hospital. She screened about 70 or 80, referred them on, 5 attended, none were treated. So, that whole exercise of 6 months was a total waste. Now, in Brighton, hepatitis C is a big problem, and what this shows is hospital admissions from hepatitis C, and you can see we are in red here, and we far exceeded in 2013 so Brighton had the highest hospital admissions in the whole of Southeast from hepatitis C. Not only that, we had the highest deaths from hepatitis C across the whole of the Southeast, and that is because in Brighton, even compared to nationally, our people with hepatitis C are extremely vulnerable individuals. So, keeping that in mind and keeping that our initial attempt to engage these people was a total failure, we thought that the only way we can engage these individuals is if we move everything to them. So, currently 84% of hepatitis C treatment is hospital based. The only way we thought we could engage these people was if we moved everything to them, and this is when we set up this first study, which is iTreat, which is a integrated test, stage and treat service for people who inject drugs, where we provided everything in the community, and this was led by Mags O'Sullivan, one of our nurses who's here today. And what we actually wanted to do was to see whether we could treat these people in a community setting, and could we cure them, or they just wouldn't attend, they wouldn't take their medication. And the second thing that we wanted to look at was to see what the uptake of the service would be, what their quality of life would be, how much it would cost to deliver such a service, because no one had any idea about how much it would cost. And then we thought we could interview the clients and the staff to assess their views about such a service. So, besides Max, who's really the backbone of the service, we had Chrissy Jones, who led on the qualitative aspect. We have Anna Marie Jones, who was our statistician and helped us with the analysis. We had Hugh Williams, who provided the psychiatric input, and we had Heather Gage, who is a health economist in the University of Surrey, who led on the health economics. And the unique aspect of our service was that it was firstly integrated, secondly it was totally a non-judgmental. We don't judge these individuals for their life choices. It was a flexible service, and we tried to deliver a personalized service. And we had two very unique things at our hand that we could use. One was this little finger prick test that we do. Often these individuals have very poor access because of injecting drug use. So, we have this finger prick test that we can use to test them for blood-borne viruses, and we have this really nice gadget here which is called as a fibroscan. Previously we had to do liver biopsies, but now this is a portable scan that we use, which within 5 minutes gives you an idea of the level of scarring. Not only that, I would turn up there as well, the social services would be there as well, the medication would be there on site. We had peer mentors, we had addiction specialists, and basically we provided everything under one roof. And what we actually found, and we've just submitted this for publication, was that we found a very high prevalence of hepatitis C in these people, 50%. So, every second person that you tested was positive for hepatitis C, despite the fact that a large number were homeless, were injecting drugs, were drinking alcohol. We still achieved cure rates in excess of 90%, which is compatible with what we see in a hospital setting. In the past, we wouldn't treat these individuals if they were drinking alcohol or they were injecting drugs, but now we treat everyone. And what we have found is that despite all the adverse effects of homelessness, alcohol excess, injecting drug use, we were still curing a very high number of people. We found an excellent service uptake, 95%. Remember, in the past, not a single person turned up for treatment, n equals 0. And here we are showing a 95% uptake of service despite the vulnerable nature of this population. Now, these individuals inject drugs, we treat them, they continue to inject drugs, they get reinfected. But our reinfection rates were quite low, because while we were engaging them in hepatitis C treatment, we were also trying to engage them in we were actually trying to engage them with the psychiatrists so that they could engage with the opioid substitution treatment. And actually the costs were quite modest. So, the cost per case detected was 170 pounds, and the cost per cure, which excludes medication, was only about 700 pounds. And then we looked at quality of life, and I don't want to bore you with the details, but we looked at a generic, a non-specific quality of life measure, and then we looked at a liver specific. The blue bars are before treatment, and the red bars are after treatment, and the higher the bars, the better the quality of life. And you can see across all the domains, even in the generic quality of life measure and in the liver specific quality of life measures, there were significant improvements after treatment. So, despite these individuals being so vulnerable, despite them having such significant comorbidity, a simple thing like just curing them of their hepatitis C leads to a significant improvement in their quality of life when assessed by validated generic tools as well as a validated liver specific quality of life measure. And then we looked at interviews. So, we interviewed clients, we interviewed healthcare workers, and what we actually found was that providing care in the community mitigated many of the negative experiences that these individuals experienced in hospital. They often felt really stigmatized, they often felt very vulnerable in hospital, but the fact that they were being provided care in an environment that they were familiar with helped mitigate all that. And the key to that was the relationship between Mags, our nurse, and them, because she was the center point for them. Irrespective of what the problem was, they could go to her if they had housing issues, if they had drug and alcohol issues, and then she could then triage them to the necessary individual. And you can see some of the quotes that which are self-explanatory. She's one of the main persons. She's so friendly. She puts you at ease. It's not like you're dealing with fearful doctors with a sense of impending doom at all sides. I mean, it was quite amazing. And you do hear about people talking about their bad experiences and feeling judged up in A&E. I think self-worth and self-esteem has a lot to do with going up to the hospital, and we kind of underestimate how stigmatized these individuals feel in hospital. And I think the most important thing is not to judge them. Many of them have had the most horrific lives. And for example, if when I was born, my mother was a cocaine addicted sex worker and my father was in prison, it's highly unlikely I'd be standing here giving this talk. So, we don't judge them for their life choices. And based on that model of care, we then got additional funding from Dunhill to develop a similar model of care in an even more vulnerable cohort, which are the homeless, who are also have a very high prevalence of hepatitis C. And this was led by Ahmed Hashim, who is our second research fellow, and this was based in homeless hostels. And we basically wanted to assess how severe, I mean, what proportion of these homeless individuals have liver disease. And I'm sure that you've all seen the recent stats which have come out on homelessness. And currently in Britain, 1 in 200 people is considered homeless. And the number of deaths from alcohol, drug use, and liver disease has gone up 55% amongst the homeless population. So we wanted to assess what proportion of them have liver disease. Secondly, we wanted to assess, will they uptake the service? What will be the treatment outcomes? And the third important thing that we wanted to look at was that we go around with this portable fibroscan looking for scarring in the liver. It's not actually been validated in the community. So those readings that we are getting in the community, are they truly reflecting true liver scarring or true liver fibrosis? So what we wanted to do was compare our fibroscan readings with certain chemicals in the blood which are known as cytokines, which are validated markers for liver injury and liver fibrosis. So what did we find? First of all, our team. So there's Ahmed. So that's Stephen Bremner, who was our statistician. Tim Worthley is our homeless GP, and Guru Ethel is my colleague in Nottingham, who helped us with the lab-based aspect of the study. And again, we found a very high prevalence of hepatitis C. 1 in 4 people had significant liver disease, and that is astronomical. And despite how vulnerable they were, we still found excellent cure rates, and we still found excellent service uptake. And to just give you an idea of the kind of population we are dealing with, you can, I mean, I think it's self-explanatory. Prevalence of alcohol intake above recommended level was 65%. Alcohol dependence was almost 50%. Drug use was 80%. And 70% had mental health issues. So this is how vulnerable these people are. But despite that, if you go out and you invest time in them and you give them time, they will engage with the service. So we have dissipated all these myths that people have that it's not worth your time dealing with these people, because I think it's important to understand that unless we engage this cohort, we are not going to be eliminating hepatitis C nationally. And the third thing that we wanted to look at was the correlation between the readings that we were getting when we were doing the fibroscans and certain levels of markers in the blood, certain cytokines, and certain other non-invasive markers. And what we actually found was that when we assessed the scarring in the liver with the fibroscan, it was significantly associated and it was significantly correlated with validated markers of liver inflammation and validated markers of hepatic fibrosis. And it was also significantly sort of correlated with other markers like TNF and interferon gamma, as well as with this ELF score, which is a validated score for scarring. So we were reassured that the readings that we were getting in the community, for example, we have found a 1 in 4 prevalence of severe liver disease. That appears to be true because our fibroscan readings are correlating with other well-established markers of liver fibrosis and liver inflammation. And the third study, which we have just started, is building similar models of care in other places like Hastings and Eastbourne, and that is Rona McGeer with the glasses, who's our 4th research fellow, who will be doing an MD, and Lydia, one of our nurses. And what has been the impact of this work? So here is deaths per 100,000 from hepatitis C before we started. Here is the national death rates. This is where we were, much higher, and now we have come down to the national level. Nationally, deaths from hepatitis C have reduced by 16%. In Brighton, they have reduced by 40%. And the reason that is because we are treating the most vulnerable people with hepatitis C. And the hepatitis C detection rate per 100,000 for Brighton is up here. It's 3 times the national average now. And we are nationally in the top 3 in our hepatitis C detection rate per 100,000. We have been commended by Public Health England. This blue bar is the proportion of people. So nationally, we have 22 national centers, where we treat hepatitis C, and we are one of them. The blue bar is the proportion of people being treated in the drug and alcohol services, and nationally we are the highest, and overall as regards treatment in the community we are in the top 3. And in the 2019 Public Health England report, we were specifically commended for this. And as well as Public Health England, we have been commended by NHS England, and our model of care is actually uploaded on the NHS England website as a good practice example. Not only that, Ahmed's work in the homeless was one of the 5 finalists in the Royal College of Physicians Excellent in Patient Care Awards. And I am sure most of you are aware, it was the 500th anniversary of the Royal College of Physicians last year, and because of that, in each region they selected a particular research project, and Ahmed's work was selected for the Southeast. And the last aspect of my talk is going to be focusing on improving symptom burden in cirrhosis. Cirrhosis is advanced scarring of the liver, and once people develop cirrhosis, they develop various complications. The main one and the most common one that results in hospitalization is your belly filling up with fluid, which is known as ascites. Now, initially when this happens, it responds to medication, but soon as the liver disease progresses, it stops responding to medication, where it is known as refractory ascites. And once you have refractory ascites, your life expectancy is about 6 months in the absence of transplantation. So, refractory ascites is in a way similar to having advanced cancer. Unfortunately, most people will not get a new liver. So, once you develop advanced liver disease, only about 10% of people will get a new liver. The vast majority will not, for various reasons, including shortage of organs, ongoing drug and alcohol use, or these people have significant comorbidity, etc., etc. So, for the vast majority of people with ascites, the management is coming in and out of hospital, coming in, having the fluid drained, the fluid builds up again, they come back in again. So, it is a real nightmare. Every 2 weeks they pitch up in hospital. There are other options. You can put this pump in to drain the ascites, but it requires surgery. It is an invasive procedure. You can put a shunt into the liver, but that is again an invasive procedure. So, for most people who have this ascites, who are not transplant candidates, the option is to keep coming in and out of hospital for this repeated drainage, which is known as large volume paracentesis. So, we in Brighton, and so Lucia in Brighton, who is a research fellow who led this work, looked at our patients who had refractory ascites to see what their outcome was. She identified 51, and as you can see, only 12% were actually listed for transplant. Despite that, virtually no patient had had any input from palliative care. So, only a third had had any kind of end of life care discussions, only 22% had been referred to palliative care, and only 16% had had advanced care planning. And I bet you that if this was someone with advanced cancer, almost all would actually have been referred on to palliative care. And even though we know that people with refractory ascites have less than 6 months to live, these patients are managed very differently from people who have advanced cancer. And you can see virtually no one had had any kind of palliative care input. So, we tried to see why that was, and we did a survey, and this was done by Leila Gelman, who was one of our final year students actually. So, we interviewed consultants, and we tried to see why people with liver disease who were palliative were not given the same amount of palliative care input compared to those who had advanced cancer. And what we found was what we had expected, that most of the consultants agreed that people with liver disease do not receive equitable palliative care. They were not quite sure of the reasons, but they felt that these were too complicated patients. So, if you are dealing with someone with cancer, you are just dealing with that symptom, but if you are dealing with someone with cirrhosis, they have symptoms that involve every part of the body, they are very complicated, they have complex social issues, and often they did not really have a clear understanding of the disease trajectory. So, with advanced cancer, we know that these patients will have generally a downward trajectory, but people with liver disease can develop episodes of decompensation where they end up in hospital, they recover slightly, they come back home, you might feel that they are recovering. So, there was a lot of confusion. So, we then looked at these long term abdominal drains. So, these are drains that are tunnel drains. You can see a diagram there. So, they are inserted in hospital and they are tunneled because they reduce the risk of infection. And what happens is that once these drains are inserted, the community nurses can manage these patients at home. They attach a little bag to the drain, and rather than patients having to come into hospital to drain large amounts of fluid every 2 weeks, in the community the nurses can drain small amounts of fluid every 2 or 3 days. The main thing is it keeps them out of hospital, it is symptom guided. So, the patients can tell the nurses how much they want removing. There are potential economic benefits to the NHS, and they are not routinely used in people with cirrhosis, because people with cirrhosis are at increased risk of infection, especially of the acidic fluid, which is known as peritonitis, and there was some concern as to whether putting these drains in would further increase that risk. So, we thought we will do a study, but we knew if we went to the NIHR, they would never give us money for a full study, because it was a very, very uncertain group. And that is Lucia Macken there with her beautiful boy Evan, who is right over there, and she led on this research. So, we sort of went to the NIHR for a feasibility randomized control trial comparing these long term drains versus standard of care, which is repeated admissions, and we took people who had advanced cirrhosis, who had refractory ascites, but they were not transplant eligible. And again, it was a multi-center study. You can see we had a lot of people. So, we had Max Cooper, who led on the qualitative, Louise Mason on palliative care, my colleagues Mark Austin and Nick Pannell, who helped with the drain insertion, Heather Gage, and we had Catherine Evans from the community, and of course, Lucia, and we had Shani Steer, who was our service user. And it was run by the Brighton and Sussex King's Clinical Trial Unit, and there were 5 different sites that were involved in the study. And because it was a feasibility study, we did not actually have any specific outcome measures, but we were looking at a number of things, whether these patients would be willing to be randomized to long term drains, what would be the attrition rates, what would be the complication rates, what would be impact on quality of life and carers, would it be cost effective, and then we conducted interviews with patients and healthcare staff. And in a nutshell, the headline data is that there were no safety concerns. We did not find an increased incidence of infection. Most of our patients could be successfully managed in the community. I think there was just one patient who needed to come in for repeated drainage, but the vast majority of people were managed in the community. The patients who were randomized to the long term drain spent 42% less study time in hospital at a total cost of and they costed the NHS 20% less. There was excellent uptake of our assessment tools, and when we interviewed clients and service staff, we found that most were happy with the long term drains, and most stated that insertion of these long term drains positively impacted their pathway. And here are some of the quotes: that much better for having the stomach drained regularly, have got my appetite back, it is much more comfortable. And again, this issue of stigma comes up, because many of our patients, when they were in hospital having their stomachs drained, they felt everyone was looking at them, because they felt that everything was self induced, that they abuse alcohol, and they were much happier in having the drainage done at home. And what has been the kind of impact of our work? So, this is right now a feasibility study. So, we are hoping that since we have got some favorable data from this feasibility study, we are hoping that we will be able to go to the NIHR to get funding for a full trial. But one of our, I think, really proud moments for the study was when we won the Royal College of Physicians Excellent in Patient Care Award in the Lancet research category, and that was quite an interesting moment, because Lucia was there with me, and it's pretty unusual for liver research to win these kind of awards. I must admit. So I told Lucia, let's just enjoy ourselves, it's highly unlikely that we're going to win. So let's have a glass of Prosecco and let's have some fun. So by the time they had announced that we had won, I was on my second glass of Prosecco, and for someone who hardly ever drinks, I must admit, and they had actually wanted us to prepare something, a speech, which I actually hadn't prepared, because I never thought we were going to win. But anyway, we won, so that was fantastic. And at the same time, the proudest moment of my life was my son. So around the same time that we won this award, my son, who is here, he actually graduated from law school in the University of Columbia in New York, and I think nothing can ever beat this. So I just thought I'll put them both together because both are really proud moments. One for me as a researcher for our team, and for me as a mother. And the other, I think, main impact is that if you want to inform change and if you want change in clinical practice, it has to be driven by guidelines. And if you look at other non-cancer conditions like heart failure and kidney disease, the reason that palliative care is so well embedded in these diseases is that it's informed by the guidelines. I'm ashamed to say that there's not a single hepatology guideline that actually makes any mention of palliative care. However, that is about to change, because we've just been asked to co-author the National Society's guidelines, and for the first time we will have a hepatology guideline that's actually going to include any mention of palliative care, and hopefully this is going to change clinical practice. I hope. I'm hopefully within time. And this is my last slide, and this is a fantastic slide of our research team, and I think everyone looks so happy. So I thought I would end with this slide. Here's Dave Cattray, who was our first ACF. He's now doing a research job at the Royal Free. Ahmed Hashim, who hopefully will submit his PhD by December. If not, I'm going to wring his neck. And he is now doing his hepatology training at the Royal Free. Here's Max O'Sullivan. This is Lucia Macken, who will hopefully submit her PhD next year. And we have Bethany Parnell, who was one of our academic F2s. And the reason I've shown this slide is that, as one of my mentors told me, that your research is only as good as the data you have, and your data is only as good as the research team that you have. And I think I've been truly blessed to actually work with a fantastic team. And I'm going to end here.